Hi, I'm Dr. Russel Libby, and I welcome you to the world of medicine. I think I can safely say that most of us either have a family member or know someone with a family member who has had breast cancer. And there's a good reason. It's the most common cancer diagnosis in women, aside from skin cancers, which we know are very, very common in a very different category. A very common affliction. Probably 1 in 8 women in their lifetime will have to confront the issue of breast cancer in themselves. That's 12% of the population of women in this country. And it has a significant mortality. Somewhere close to 40,000 people will die this year of breast cancer. And it's a very significant disease that knows no boundaries, no borders, many ages. Lots of women in their 20s and 30s will get this disease, as well as older women. It's more common there. But it's something that people can be aware of and actually detect early. With early detection, somewhere close to 95% may see a very significant long-term survival. It's something that we really need to impress. We're going to learn about breast cancer. We're going to learn about the signs, the symptoms, what people experience if they have symptoms that might let them know. We're going to learn about screening, because often screening is the only way people come to find out. We're going to learn a lot about what people go through, and we're going to learn from our studio audience the experiences they have had. We've got a very wonderful audience of women who have had breast cancer. Some still, I guess, once you have it, you think you have it for life because you just always have to be aware of it. We're going to learn about their experience, and we're going to take that experience and learn really what you need to know about breast cancer screening, prevention, and ultimately how to deal with it. We have Dr. Nicholas Robert. He is a breast cancer specialist and oncologist here in Northern Virginia, and he's taking care of some of these ladies as well as many other women in Northern Virginia. He's going to help us fill in the details so we get to understand exactly what it all means. So I'm going to start just by surveying what and how you all have been diagnosed. Now, you were diagnosed with breast cancer how long ago?
8 years ago.
8 years ago. So you've got a strong history here, and currently are you holding up pretty well?
I think so. I'm a survivor.
And what was the situation when you first detected that, or did you have any signs and symptoms?
Yes, I did, and I had always expected this day to come. My mother had died at 86 of breast cancer. My sister had it when she was 43, my older sister, premenopause. And so I knew that that day could come. So I very faithfully did all of my mammograms. I was always checked. And about 3 months before I was due to have my normal yearly checkup, my 41-year-old niece got cancer. So I was going through it with her, and then it was about a month before I was due for my 12-month checkup, and I found myself, when I examined, I found a dimpling in my breast. And so it was 3 months before my son was getting married. And I thought, should I just forget about it? Should I postpone it? What should I do? Well, knowing the history and knowing what, it was not a new disease to me. We'd been studying it for my niece. So I went in early to my gynecologist, and he didn't find the lump, but he sent me and I showed him the dimpling, and he sent me to a surgeon, and immediately he said, there's your lump, and it's malignant.
So you were in a situation there where you were so familiar with the disease, you were willing to put off.
Yes, I was willing to put it off for 3 months if I could get through my son's wedding. Yeah. And I didn't, and I went and I had a lumpectomy, and then he sent me to Dr. Robert, and I said, through my tears, I said, please, please let me wait 3 months. And he said, no, I want you to live to see your grandchildren. And that's all it took. And now I have 3 wonderful grandchildren, which I didn't have before.
There can be a happy ending.
So there can be a happy ending. So I was bald at my son's wedding. I had a beautiful wig. I didn't have to go to the beauty shop that morning. And my hair looked good all day. And so it was worth it. I had some determination to get through, and I did. We had a wonderful time. And now
That's inspiring. That is. And how old were you when you were diagnosed?
58.
58. Okay. And your story, how old were you when you were diagnosed?
47.
47. And was it a total surprise?
It was was not on my dance card. There's no history, no family history. I, interestingly enough, was scheduled to go in for another procedure, a voluntary procedure the next day, and I found a lump.
And that was it.
And that was kind of it.
That's where it started. We're going to find out more about how that happened with you. How old were you when you were first diagnosed?
43.
43.
Yes.
And how long ago was that?
About 2.5 years.
And the situation for you?
Well, I actually had been told by my mother as I was growing up that both my grandmother and both of her sisters on my father's side had breast cancer. So she was always on me to be checked and to make sure I stayed up with my mammograms and all that. And I even at the age of 35 insisted when I belonged to an HMO that they give me mammograms at 35 because I think the age is really 40 for most people. And I had to fight for it, but they did do it. However, I got to about, I guess with my first child, I was about 36. And after I had my first baby, I got very caught up in my life. I was very busy. I had a full-time job. I was a mother. And I did not have a mammogram for 3 years. I also did not go to my gynecologist for 3 years. In that time, you know, I don't know how cancer works, but somewhere along, I'd always been very diligent. When I went, after that 3 years, I went for a clinical exam with my gynecologist, and he did a breast exam. He found the lump. And thank God I went, but I wish I had gone regularly through those 3 years that I didn't go. But he found it and sent me to an internist, and they did, the biopsy came back inconclusive. They did, I told them I wanted it out. I didn't care, you know, just take it out just in case. They took it out and they found out it was cancer. So it was very traumatic for me because I have young children.
Well, you have some very interesting details that we're going to explore.
Yes.
And yourself?
I was 63.
63.
2 years ago. And it was found in a mammogram.
So this is a routine screening?
Routine screening. I had absolutely no symptoms. I was stunned. I was floored. Couldn't believe it. No family history. None whatsoever.
And you were stunned?
Absolutely.
Absolutely. Were you there with her for the mammogram, or
No.
at this point, this is a yearly kind of thing? You know, it's
routine.
Routine, right? But cancer occurs. I mean, it happens. 1 in 8 women, it's going to happen, right?
Not to her, though.
Not to her, right? It never happens to you. I mean, you're invincible. You'll be able to do whatever you want until you can't do it anymore, I guess. But when does that happen? And that can be a surprise if you're not careful. And you?
I was 45.
45.
And in around December '05, my husband noticed a small lump under my arm, right up below my armpit. We said, didn't notice that before, and it hurt when you touched it. And so I called my GYN, and I thought, I didn't know what they would say, but they got kind of excited and said, why don't you come in this afternoon?
I would imagine. Yeah.
And that started the ball rolling.
Right.
And we went from that to the general surgeon checking it and couldn't excise it. So he said, well, we should take it out and take a look at it. So I just kept taking the first appointment that everybody would give me. And he took it out March 6th, and March 10th we found out it was malignant. And it just looked like this little bitty lump stuck under my skin.
You found it.
Mm-hmm.
Yeah. And I'm taking it that you have not made a career of doing that on other people. Oh, that's good. I'm glad to hear that. Great. And I'm sure you're glad to hear that too. Did you know what you were looking for? I mean, is it something that was in your mind, you know, these are things that women should do, that men should help them do, or things of that nature? Was it just something that sort of caught your eye, or?
Yeah, I think I noticed it one day and didn't really say anything, and then saw it again another day and said, "Oh, there's a lump under your skin there," and she felt it a little bit and said, "Well, maybe it's nothing." I said, "Well, maybe it's something.
Right.
Maybe it should get checked."
Yeah. Well, I hope you're making him go to the internist and at least getting him colonoscoped, huh? No? We're going to make sure make sure. Any which way. And how old were you at the time that you were diagnosed?
I found my symptoms when I was 34, and I was diagnosed actually on my 35th birthday.
Is that right? So 34 goes to show you that it can happen when you're pretty young. And what were the circumstances?
Mine was a very big surprise. I go in for just a routine annual exam with my gynecologist. I'd had one in midsummer. It was September, and I was just getting dressed one day, putting on my bra, and I found an abnormal rash-looking thing on my skin, and my skin was kind of thick. It was like a swelling kind of a thing. Mm-hmm. I was able to call that day, and my GYN got me in immediately, not because there was anything of concern, but just happenstance, and that started the ball rolling. And when I went to get the mammogram and sonogram, they found that it was a BI-RADS category 5 mass in there as well. So
it was real.
Obvious, yes.
I mean, you were lucky, you were sensitive to it, and just by chance, the right thing happened.
And it came on quickly in my case, which was the other pretty significant thing.
It is pretty surprising. And how about you?
I was 43 when I was diagnosed. My mother died of breast cancer 6 months before I had my mammogram. I had been having mammograms all along, but they discovered a very, very small cancer when I was 43, and that was 16 years ago. I went 9 years with no cancer and got metastatic disease in my bones 7 years ago, and I'm a survivor. But it's been rough. I've been through lots of rounds of chemo, and but I'd like to be the poster child of longevity here. So.
And you've been watching it all. Yep.
Yep.
And I'm sure you've been pretty supportive through all that process too.
Oh yeah.
Yeah. It's a lot of work, actually.
Yeah.
So, Dr. Robert, we've actually heard something interesting. Most people would think that these kinds of cancers could come later in life, but most of the women here were in their 40s.
That's right.
One was in her 30s. In fact, the younger 30s. What are the ages that we expect to see?
Well, I think when you actually do look at numbers, the majority of women who develop breast cancer are over their 40s, over their 50s, and many in their 60s. Mm-hmm. It is a disease that occurs as we get older. So we have a group here, small sample, but relatively young women developing breast cancer. But I think it's important to notice that people notice lumps. And there's been some controversy about breast self-examination, how important it is, challenging that it is important. And I think you've heard that it is important. Mammography has been really the gold standard for picking up early breast cancers, but you can't depend on mammography alone, especially in women that are under 50 when the breasts are dense, and the mammogram can give you what's called a false negative. So learning to do a breast self-exam on a monthly basis, being comfortable with having your breast examined, I think is a good idea. And there are women I see that come in not because the mammogram was abnormal, but because there was a lump that was identified and they paid attention. The other thing you heard, which I think is important, is the idea that there's no one in my family. We have some people who have strong family histories, but we also have some people you heard, there were no family histories. There was really no reason to think they should be diagnosed. But breast cancer often is so-called sporadic. There is no family history. So if there's a change in your breast, it's important. We heard also about a rash. There is a diagnosis called inflammatory breast cancer. It's uncommon. It represents about 1% of breast cancers. But that's a rash that, if you have a rash and it doesn't go away in a day or so, don't think it's some sort of infection. You really do need to see your doctor. And I was really pleased to hear that everyone talked about seeing their doctor. Their doctors were very, very responsive. And I think that's one of the good things about the way we practice medicine in this area. People are responsive and people are brought in, and the ball moves pretty quickly.
Well, and you had a remarkable element in your history, and certainly, I guess, when you think of the genetic element, it plays a big part.
Yes.
But you didn't really have the insight to really be aware of it. Give us a little perspective on what happened with the genetic background for you and your cancer.
Right. Well, when I started being seen in my 30s and when I demanded to have mammograms at the age of 35, I did it mostly because my mother was constantly telling me, your dad's mom and both her sisters had breast cancer, and one of them actually died of ovarian cancer. My mother was actually more of a proponent than my doctors at that time. Back in those days, in the 90s, they were just beginning to understand the genetics of breast cancer. And so I I eventually did hear about, BRCA1, BRCA2, and I asked my doctors about it. But for the longest time, I was told, well, it's on your dad's side. So it doesn't matter. It only matters if it's on your mom's side. So I sort of felt safe for a while. And then, I brought it up again, and they said, well, it does matter that it's on your dad's side, but it doesn't matter as much. And then as time went by, that changed again. It was, no, it's actually also important if it's on your dad's side. But you don't have any first-line relatives that have breast cancer. Your mom doesn't have it. You don't have a sister that has it. You don't have an aunt that has it. So, you don't really need to get tested. So I didn't ever get genetically tested until I actually got breast cancer. And even after I got it, there wasn't anybody really pressuring me to get tested. I really had to push hard for it. And because my oncologist at the time, which was not Dr. Robert, told me, you'll never have it. Only 10% of the population has BRCA1 or BRCA2. You're not going to have it. And this was after I had gone through chemo. I had a lumpectomy, and I was trying to conserve my breast. And by the time I insisted, right before radiation, because I was like, hey, I need to know, should I go to radiation when I might have the BRCA1 gene and I might have to take both my breasts off? Does that make any sense? And they said, no, you're right. If you're going to get tested, you should do it now. So I went, I had the test done, and it came back positive, which was really very difficult to hear at the time. So, I was one of those 10%,
right.
but...
Right. Well, and she's talking about the fact that she has a family where actually she had no direct descended women at that time who could have had breast cancer. Tell us a little bit about the genetics behind it and really what we know, because I think that that's such an important part of people being aware, and it also sort of dictates how you get screened.
Right. I think what you just heard, I worked with a very prominent surgeon in Boston years ago, and we're talking years ago, and this thought that breast cancer was really from your mother, not from your father. And he had to admit that that was the way he understood things. So it was really ingrained, I think, in the minds of people. But when you really think about it, a man can carry that gene, but it's unlikely he's going to have breast cancer because less than 1% of breast cancer patients are men. So they can carry the gene. And knowing that history about your father and the breast cancer on your father's side, now I think is a red flag for most of us. But it is important to get some advice about that, and I think we're fortunate in the area to have genetic counselors available who really dive in and get a better history. But finding that history is important, and then pursuing it, realizing that maybe there's only a 10% risk, but the implications of a positive test is frankly huge. We haven't talked about breast MRIs, and there's a lot of controversy where they belong. But breast MRIs today are done very well. They clearly pick up cancers earlier. It's a test that probably we don't need to do on every patient, on every woman. But it is a test that in women who have a strong family history, actually regardless of BRCA status, but if they also have a BRCA mutation, they should have breast MRIs. That's considered routine if they're not going to have prophylactic surgery. And then, so I think the issue is knowing your family history, not just on your mother's side, but your father's side. And then if you run into a bit of a wall in terms of getting the test done, I think getting some genetic counseling and pursuing that is a good idea. There's another area in terms of breast cancer risk, and this is not a gene that has such a strong impact. If you have a BRCA abnormality, the chance of developing breast cancer in your lifetime is 85%. Pretty strong. And half of those women, it's before the age of 50. So young women, that's a bit of a tip-off, especially under the age of 40, that maybe there's a genetic concern. But there is another set of genes, which I think that story is just beginning to unfold, that have a lower risk for developing breast cancer, but there are multiple genes. And I think as you see the story unfold over the next few years, we'll begin to do other testing, not just BRCA1, BRCA2, but other genes will be tested, I think, in the future. And that will help us cone down on those women that are higher risk. Because when you think about it, 1 out of 8 develop breast cancer in a lifetime, but 7 out of 8 don't. So it'd be nice to have a better idea who's at risk. And I think this new testing, as it unfolds, may help us.
So who of you who had the BRCA positive?
Not positive.
Not positive. You were positive. Nobody else?
My family, my sister and
Yes.
her niece and
Yes.
her daughter, excuse me, and they were not right.
Yeah,
They were not, yes.
And that's an important point. If you are BRCA tested, but you have a strong family history of breast cancer, it doesn't mean your family history has gone away. It only is helpful if you have someone, if you have breast cancer and you're worried that your sister might have breast cancer, if you're BRCA positive, and if your sister is tested who doesn't have breast cancer and she's negative, then she has a low risk. That's where it's helpful. But one of the things people have to know is, and breast MRIs is a good example. If breast MRIs have been shown to be helpful in patients with a strong family history or BRCA positive. So if you do the test and it's negative, regardless, your follow-up, I think you need to watch things more carefully.
I'm wondering, do you think you had any risk factors other than just being a woman?
Other than being a woman and being 63 years old.
Right. So one of the risk factors we understand has to do with estrogen and the fact that the longer you have high levels of estrogen, the more significant your chance for developing cancer as you age. And that's a pretty uniform kind of approach. So that's a risk in and of itself that has certain connotations.
Right. If you think about it, and it kind of makes a fair amount of sense, when a woman goes through her cycle, her breasts are stimulated and proliferate. So you have dividing cells. And the more cells divide, the greater chance of a mistake occurring, a mutation that can lead to a cancer. So a woman who starts periods in her life early, let's say under the age of 12, continues to menstruate, especially without an interruption with a pregnancy, and especially if it's been postponed after the age of 30, and then continues to menstruate beyond the age of 50. When you look at it all together, that increases the risk. The practical implications of that, though, are somewhat daunting. I mean, your periods start when your periods start. Right. Pregnancies occur when pregnancies occur. In our society, a lot of women are professional women, and there's a time to develop your career, there's a time to have children. So it's just one of those things. So you should know that those are considered minor factors. Mm-hmm. One thing that's hit the scene, which is getting much more attention if you want to look at reducing your risk, is being that body mass index that you're supposed to be. Using a combination of exercise and diet to keep your weight down. That story is beginning to unfold, not only in reducing your risk for developing breast cancer, but also in women who are diagnosed with breast cancer, reducing the subsequent recurrence. So we're beginning to see a greater emphasis on diet and exercise. Nothing magical, unfortunately, with that recommendation.
But these are subtle risks, and when you're talking about such a significant proportion of the population that will eventually get breast cancer, those subtle elements can be very important in forestalling or prolonging life without.
Right, and if you really look at the big risk factor is family history. So, when we heard about someone getting a mammogram at 35 with a strong family history, well, that was the right thing to do. And the American Cancer Society, for a while, that was the baseline, some of you may remember, and it's been pushed back to 40. But a strong family history and learning who had breast cancer in your family, at what age. We heard about someone being premenopausal. And one of the sort of standards we use, if you have someone in your family that has breast cancer, especially if they're under the age of 50, you should start having mammograms 10 years earlier. And the issue, and you really need to discuss it with your gynecologist, is the role for breast MRIs, because that's raising its role as something that's important to do in some women.
Right. So, did you have daughters? Do you have children?
I have sons.
Do you have sons? Okay. And your genes are negative for it. So you were one who probably was just one of those 1 in 8 that was going to get that to happen.
And I had an interesting situation, and Dr. Robert may wish to speak to this. I was estrogen negative. So I faced either going through chemotherapy, which wasn't indicated through the size of the tumor, mm-hmm. or the fact that I had no lymph nodes involved. And the recommendation, both by Dr. Robert and my gynecologist, was, well, you might want to think about it. So even though it appeared initially that I wasn't going to have chemotherapy, I did have to go through chemotherapy. So.
A choice to make. And we'll talk about treatment in a little bit. I want to get a little more perspective on how things evolved. So you had a lump, you got examined quickly. Did they do a mammogram? Had you ever had a mammogram before that time?
I had several mammograms, and
Okay.
they had never shown anything suspicious. And I was actually, after I'd started the process and had this one looked at, I was due for my annual mammogram. So they just changed it to a diagnostic and added the ultrasound, the sonogram, to go with it, to check it more. And they did that right away, and the radiologist gave me the report that said, come back, it doesn't look bad, come back in 6 months and we'll check it again then. So I took all the pictures and I took everything and I went back to the surgeon and I said, okay, what do we do next? And didn't wait. And I did go back and tell them, but it didn't, it was, the lump was so far into the tail of the breast, the way it was explained to me, that it was in a location that just was not picked up well on the mammogram. And then before, as a preparation for my re-excision, though, afterward, is when the MRI came into play for me, as they used the MRI to check further to try to decide what type of surgery would be best.
So you had the MRI, and that was pretty much where the extent of the diagnosis was discovered.
It was for this. Right, it was for the re-excision, and it was to try to see if there was anything else at risk and how extensive to do for the re-excision and whether a lumpectomy would still work.
Right. And just out of curiosity, what did you choose to do from that point of view in terms of a lumpectomy versus a mastectomy?
I agreed with the surgeon in doing breast conserving surgery and doing the lumpectomy. He took a little, because of the results of the MRI and seeing what we thought were a couple additional small masses, he took a little bit larger area, but still felt comfortable doing the lumpectomy and radiation.
So we have diagnosis with mammography, we have MRIs, those are used to get more specific and if you have a higher risk.
Right.
And are there other kinds of tests that people should be doing at some point or another? So we have genetics, we have the radiology, we have breast self-exams. Why don't you give us a little overview of the ages and what is appropriate in those ages for examining? How soon in a woman's life should she start with self-exams?
Well, I think in her 20s when you begin to do breast self-exam, I mean, the chance of developing breast cancer before the age of 30 is pretty small. It occasionally happens, but it increases from 30 to 40, and then mammography is recommended starting at 40, and this is assuming there isn't a family history. And then there is some controversy, but most of us think that mammography should be done every year starting at the age of 40 and continuing. And when to stop, whether it's age 80, we can debate about it, depends on a lot of factors. What a change in terms of mammograms is the fact that what most people get now are film mammograms, but we now have digital mammography, which is more sensitive. And there was a nice study looking at thousands of cases which showed that there was about a 15% increase in sensitivity with digital mammography. Unfortunately for the patient, it doesn't make that experience any more pleasant. You heard about when the tumor is a little bit on the peripheral aspect, it's harder to pick up. Well, women will tell you that the technicians try very hard to get every cell of your breast on that plate, on that picture. But the reason is if you're not pretty rigorous about it, you can miss a peripheral lesion. So if someone has a lump, they know there's something there, but if they don't have a lump, it's really important to get as much breast tissue. So digital mammography is really replacing film mammography in younger women with dense breasts. The breast MRI story clearly has a role in women with a family history or BRCA abnormality. And in a mammogram that is a question mark, or an exam that's a question mark, then a breast MRI is something to think about. The other thing I would say is, and I remember years ago being in a meeting and someone said, you know, if the lump is in a young woman, you don't need to worry about that lump. And a lump is a lump, and regardless of any study, except maybe an ultrasound that shows it's a cyst, and it's aspirated and the lump disappears, a lump should be removed. If you feel a defined lump, I think you were told about maybe you had an option of a 6-month follow-up. It sounded like you didn't do that. And that was a lump that needed to be removed. So the mammogram or even an MRI, if it's a real lump, the best thing to do is just for your own peace of mind is to remove it and be sure that it's not something serious.
So we've talked about, okay, the risk factors, age, total estrogen in a lifetime, and whatever variety of ways that may be, whether it's early onset of menstruation, late menopause, no pregnancy, no lactation, no breastfeeding, those things that would interrupt the estrogen exposure. Obesity, or at least having a high BMI, where it's suspected that your estrogen production is a little bit higher when you have extra adiposity, right?
Correct.
And then things like smoking. I mean, smoking is responsible for every kind of cancer, isn't it?
Well, it probably doesn't play an important role in breast cancer.
Okay. How
but
about diet?
Diet, and
Yes.
The diet issue is really weight related. To diet well probably means reducing your fat intake. If you reduce your fat, it's easier to lose weight. And there's also, I mean, we also have to worry about other things like our heart. So a good diet leads you to a better situation in terms of other aspects of your health. The trouble with weight, to do it solely by diet, you really need to exercise. And then you have the spin-off that's also better for your cardiovascular system. The other thing that's been in play is hormone replacement. And hormone replacement for many years, decades, was felt to have a role in improving the long-term benefit of women when they went through menopause. Certainly menopausal symptoms are ameliorated with hormone replacement. But it's interesting, I mean, there's some good news. We haven't talked about treatment, but some of the things we have talked about early detection has led to reduced mortality from breast cancer because of early diagnosis. But hormone replacement, especially using combined estrogen and progesterone, that looks like by reducing that use, we've seen a reduction in the number of women diagnosed with breast cancer in this country in the last few years. And I think if that trend continues, I think we'll link pretty nicely that hormone replacement that we use with good intentions probably does not have a role in a lot of women, especially long-term hormone replacement. So that's another way to reduce your risk.
How about birth control pills?
Birth control pills have been looked at just about every way you can, scores of trials, and there is not a good linkage between birth control pills and the increased risk for developing breast cancer. There was maybe a concern early on with higher estrogen birth control pills, but that's pretty well gone. So I don't think we need to feel that the use of birth control pill really increases risk.
And of course, the other risk factor that you would expect that most who have experienced another cancer and a treatment for that cancer might be at risk for breast cancer as well.
There is a story that it only fits for a few women, but the disease, Hodgkin's disease, is treated with radiation. And radiation exposure in a young woman under the age of 30 is associated with increased risk for breast cancer. So that's a group that should be watched more carefully. There are some exceptions like that.
Right. So we have any other risk factors that we want to talk about?
I think we've covered them, but we have a very astute group here. Did I miss anything?
How about alcohol?
Alcohol.
Oh, okay, let's drink to that. Alcohol has a two-sided story. If I was a cardiologist, I would say I would encourage you to have at least one glass of wine. I guess if I was a gastroenterologist, I might encourage more. But as a breast cancer doctor, it's good to preserve your heart, but more than a glass of wine or a drink a day probably it should be discouraged. Yeah. I say that as a French Canadian. Right. It's hard for me to say it, but I think it's probably
a wise psychiatrist. I'll
stay out of that one.
All right, all right. So here you go. You've had your diagnosis. Mm-hmm. You've gone through the staging and the workup. Mm-hmm. And what were your choices?
Well, which time? The first time through, I had a very small tumor, no lymph nodes, and I went ahead with the chemo because I didn't really want to take any chances that I would have any recurrence. And I also had a bilateral mastectomy by choice because my mother had breast cancer and died. And I thought, I've got it taken care of. I'm not getting this again. And 9 years later, I developed it in my bones, and it was a big surprise. I've, of course, been through lots of rounds of chemo since then. I was on one chemo for 6 years, actually. I had to get taken off of it because of the neuropathy in my feet. And right now, currently, I'm not on chemo, but I'm calling it my chemo vacation, but I will be back on it eventually. One thing I wanted to mention was I have a daughter who's 29. My mother was diagnosed with breast cancer when she was 54 and I was 43, and my daughter is now 29. She is being proactive, and she's going to have an MRI and a mammogram very shortly, and she's also consulting with a surgeon, and her doctor, her GYN doctor, felt that was very important for her to pursue this. We haven't been genetically tested. My doctor said he didn't think there was a reason for us to do it, because at the time we discussed it, we were worried about whether we'd be covered with insurance. We didn't get tested, and also my daughter was in her early 20s, and he said it's like an axe over her head. He'd rather she didn't get tested. If she wanted to get tested when she was in her 30s, that would be her choice, but in early 20s, he didn't really want to have her tested for that. So, but I've been through lots of chemo, and here to say that you can go through anything and you can still keep going.
Right. Well, yeah, you can be a testimony that the process of your experience with your treatment, you went through a number of surgical procedures.
Not really. I had a bilateral mastectomy,
right.
and that was the surgical procedure. That was it.
And then reconstruction with that?
No, I just chose not to have reconstruction. At the point when I had breast cancer, they were having some problems with people having silicone go through your body, and I thought, that's it?
I don't need anything else, right?
No, I didn't really want to deal with that. And I also, at the time that I discovered I had breast cancer, I also discovered that I was going to be going through a divorce. And at that point, I couldn't deal with anything else. So I just decided to have a bilateral mastectomy, and that was it. So.
You're a pretty strong person. I mean, the fact that you can sit here and talk about it, and you've had a recurrence of sorts with the mets in your bones, as you describe them, and you're living well with those.
Yes.
And you're living life to its fullest.
Yes, I'm enjoying it. I retired recently, and I actually had to stop working and go on disability because of the chemotherapies and the side effects and things of the problems that I had. But what doesn't kill you makes you strong.
Right. Well, it's an amazing story. You had choices with your treatments?
Somewhat. Mine were dictated by the fact that I had inflammatory. So some of my key choices were to determine whether I was going to have surgery first or the chemotherapy first, for example. Also, inflammatory breast cancer is difficult to diagnose, and so there were conflicts in my doctor's opinions. And so I think my choice was more along the lines of how aggressive do I go, what assumptions do I make, and how aggressively do I pursue this. And I chose the most aggressive route.
Yeah. And so at that point, you have had follow-ups. Are you cancer-free at this point?
I am. I just finished treatment a month ago. So, yeah,
I'm still early.
About 15 months out of my diagnosis right now.
Tell us a little bit about what the choices women have in terms of the way they approach it for treatment.
Yeah, let me just comment a little bit about genetic testing. There was a period for a number of years where there was a real concern about discrimination if you had genetic testing. And I think in someone with a family history diagnosed in her 40s, you may want to revisit that issue. It is a simple blood test. We actually now contact the insurance carrier to get pre-authorization. So it's much more transparent, it's much more open. And that might be a thought, because in a family where there is someone affected with breast cancer and there's a relative worried about it, if that family member is positive and that relative is negative, that's good information. And that may affect how they think about their screening. In terms of choices, it is really fascinating. You know, some of us grew up, everyone had a mastectomy. Many years ago, I trained as a pathologist, and the surgeon would come in and just say, "Is it cancer?" And the woman would be asleep, and she would wake up, and she would know the diagnosis, depending on whether she had one or two breasts. Right. And we have changed so far from that, where many women today are able to just be treated with lumpectomy and radiation, And frankly, after a little while, sometimes I have to either look at the chart or ask the patient to remember what side was treated. And that's done without sacrificing chance for cure. Now, certainly there are some patients that are better served with a mastectomy. But it is a choice, and I think it's very important when you're seen or people are being evaluated to be seen by all the right modalities. The surgeon is key, obviously. The radiation oncologist is someone that should hear about the case in most of the situations, if not all, and then the medical oncologist. There are certain situations where giving treatment with medical oncology earlier may be appropriate, but that team needs to be someone, a group that you see, a team that works together. And it's really interesting, breast cancer, when you look at the modalities that are involved, they're really, the interest and the focus is what's best for the patient. You know, the surgeon is quite willing, if a lumpectomy is the good choice, a lumpectomy is fine. If the mastectomy is better, and where there may not be a role for radiation, the radiation oncologist will back out. And in terms of medical oncology, we've heard a little bit about the tough decisions that are made, but you know, it's ideal when one of us as a medical oncologist can say, just take a pill and you don't have to take any chemotherapy. I mean, we know what people want us to say, but there are some tough decisions. There's some new work that's being done to help us guide. But you heard earlier, you know, someone small tumor, lymph node negative, everything looking good. Surgeon probably said, we're done, you're out of here. But then hearing that the receptors, the hormone receptors, which is a favorable finding, and a finding that permits you to use pills, not chemotherapy. If those hormone receptors are not there on the tumor cells, then chemotherapy has more of a role, and there is a risk even with small tumors for recurrence. The good news is that the treatments, I think, are getting better. And so the ability to get through it is better. And lastly, I just want to say, you've heard about someone with bone involvement and metastatic disease and living with this for years. And it's a different situation, but you can look in the eye of someone who has that situation and tell them honestly that this can be a chronic disease. It's not quite like hypertension, changing medications to keep your blood pressure down, but there are many choices today that we didn't have 10, 15 years ago. So when you hear about all the research that's being done, when I started, there was a handful of drugs. Now there are 20+ drugs available. And the idea that if someone's cancer comes back, in many situations, not all, but many situations, you can keep that cancer under control and someone can live with some quality of life for a number of years.
So, and you have the situation here where you've all had some form of surgery. What was it to you when you first discovered, okay, I'm going to have surgery? Did it affect the way you think about yourself in a way that, that really overwhelmed you? Did you feel sorry for yourself?
I didn't do the why me. I was very much almost like it was happening to somebody else. I can't believe this is happening. And I think I also had the impression that I would have choices. In my case, I did not have choices. I found a lump. I had a mammogram. It was all confirmed. I went to the surgeon. She did a biopsy in her office. Within 24 hours, I knew what it was. And as a precaution, she sent me for an MRI, a breast MRI. And it was through that process we actually discovered that there were 2 very small additional growths that were not detectable on a mammogram. And so my choice went away. Right. And so I was... I knew my life was never going to be the same. I knew I would never look the same again, and I think I struggled with that.
Right. And did that affect the kinds of procedures that you chose? I mean, there's talk, okay.
There wasn't a choice. I had a mastectomy.
Did you have?
I had reconstruction,
okay.
and that was actually, several people urged me, my gynecologist urged me to really consider that, because initially I just wanted to have the cancer removed and get on with it. And he said, it's not a medical emergency, take some time, do the research, and be comfortable, because you're going to survive this. Right. And you need to feel good about yourself afterwards. And reconstruction is an option for you that will help restore a sense of normalcy.
Okay.
So you really need to look through, do the research, look at those options, and take the time to make those decisions.
And are you happy and comfortable with the outcome?
Yes.
It restores your self-image.
It helps.
It helps. But you learned a lot about yourself in the process.
You know how strong you are.
Yeah. Do you continue to take medicine?
Yes. I take a new class of drugs.
You take a new class of drugs. And these medicines are intended, how do they work?
Well, Dr. Robert can explain. What I take is called an aromatase inhibitor. So a chemotherapy put me in menopause.
Okay.
I was concerned about staying there, so I prophylactically had my ovaries removed.
Right.
Mine was very estrogen driven, so I didn't want to give it any fuel,
Right.
just in case there was a cell left there somewhere that chemo didn't get. And then the aromatase inhibitor, as I understand it, turns off another process that can convert to estrogen.
Right. Okay. So we know that estrogen's a big driver of these tumors, and she had her ovaries removed. Did you have your ovaries removed?
No, I was past menopause.
You were past menopause when that happened.
And
so
I'm taking the same medicine. Yeah.
There wasn't something you could do about that.
Yeah.
Right. How about you?
Actually, I opted to have a hysterectomy, a full hysterectomy, because I had a very high chance of getting ovarian cancer because I was a BRCA1 carrier. The other reason is just that I looked at all the research, and somebody with BRCA1 having a bilateral mastectomy and a hysterectomy or oophorectomy, you can do either one, it really improves your chances of survival. My cancer is triple negative. So that means it's ER, PR negative, estrogen, progesterone negative. It's also HER2 negative, which means I also have a very aggressive cancer, and that, aromatase inhibitors and estrogen blockers and things like that do not work for me. And my cancer is not fueled by estrogen.
Right.
So it's also very frustrating for me because the only option I really have is surgery and chemotherapy. So I can't go on, the kind of therapy that Adrian's on here. So I'm constantly waiting for the day when they come up with a treatment for, negative ER, PR negative cancer. So I feel you as well.
So we have so you have the surgical approach, and then you have the chemotherapy, as in an aggressive chemotherapy to knock out cancer cells, and then you have another kind of chemotherapy that Adrian was talking about, which is to suppress the production of estrogen.
The so-called hormonal therapy.
Hormonal therapy.
Which is a very effective form, but as was pointed out, that takes care of a majority of breast cancers, because majority of breast cancers are estrogen receptor positive and fueled by estrogen. But there is a minority that's real, and and we don't have any drugs other than chemotherapy to use for that type of cancer. I think it's a question of only time that we identify some markers and some other ways of treating. Excuse me. And then the other thing is we did talk a little bit about radiation, but it's used in patients with lumpectomy, but it's also used in patients with mastectomy and reduces the risk.
There has been a trend to some extent with the advent of some of the more acceptable cosmetic outcomes of the, reconstructive surgery. Some women choose, when they have the certain types of cancers, to have both breasts removed prophylactically. And in some situations, and I don't really hear the story here, but there are some families where women without ever having cancer will decide, you know what, I'm not going to take that chance. What's the situation?
Yeah, there's some science to support bilateral mastectomies. I mean, you heard about a situation, if someone is BRCA positive, the best way to reduce your chance of developing breast cancer is with bilateral mastectomies. In a patient who has had a tumor that's hormone receptor negative, less options for treatment in the future, that makes a lot of sense. But there are certain situations where there is an enormous amount of anxiety. Someone's had breast cancer, they have a family history, they're BRCA negative, they don't have evidence for genetic relationship, but the issue of being followed is something that you have to consider. I think it's a minority of people, but it's something that we need to address, because at the end of the day, what you heard from people is that they have to readjust, and you need to figure out what to do so they can readjust and move on in their lives. I mean, being a breast cancer survivor, the emphasis is being a survivor, returning to whatever you've been doing. So I think we need to figure out as a group together, when you're taking care of a patient, what's best for them. Sometimes it means, bilateral mastectomy.
When you had your diagnosis, I mean, you had a pretty rapid evolution. Did you think, maybe I can get away with something else? Are there other treatments that you were immediately running to the internet to try to figure out, is there some other way I can treat this?
You mean besides the lumpectomy?
Yeah. Or besides lumpectomy and what else you've gone through with?
I think I did a little research, but I ended up at the doctor's so quickly and to a surgeon that he went through and we listed out. I mean, he diagrammed out the different options, and I was very happy to have the team that Dr. Robert described with the medical oncologist and the radiology oncologist, and they were all there and mapped out the options in the plan. And so we took a little time to research further, but at that time it seemed like a pretty clear plan with a good outcome.
Right. It's a sophisticated process, and all of a sudden you realize that you have a lack of real information. Did you go to the internet and try to find alternative information?
No, I'm not a real good researcher myself. Probably my role was to listen to Beryl, who did do some of the research, and when the doctors explained the different options to us, we had some other assets available. Her father's a dentist, and she has a godfather who's a surgeon, and he continues to stay involved in medicine. And we have a pathologist who's a friend, and so we just called all these people and asked them, what parts of it they knew about, and that just really helps you understand it. You really have to go through the information again and again. It's kind of painful and worrisome, but each time you walk through it, you understand it a little bit better. For the surgeons, it's very clear. They can map out, here's the probability of this, probability of that, we should do this. And you're like, how did we arrive at this decision so quickly? Well, they've been through it so many times. And so rehashing the information and talking it through again and again really does help, even though you don't think you're going to find some new answer, but you do help understand. Right. You understand it as you go through it again and again.
It does take time and patience to go through it over and over again. When you had to go through your process, did you look to the internet? Did you try to find some things that might give you some alternatives that would make you feel like you were contributing to your care?
No, I turned to Dr. Robert and to my own oncologist. I did later. Okay. I went out on the internet and did some research. And one of the things that I did for myself later, was got involved in the Why Me organization in their peer-to-peer counseling program. And I'm in the process now of being certified as a peer-to-peer counselor, so that I will have the opportunity to maybe share what I went through, but to more specifically share empathy and compassion as a survivor to women as they begin to go through it.
And you're a strong and a very friendly person, so I think that it would be great if I had to go through something and you'd come and reassure me that everything was going to be okay.
I'd like to hope so.
This is how it works, yeah. And I think that's an important part of the process. You all have been involved in some of the support groups that are out there, and some more actively than others. What organization have you been working with?
Outside of fundraising, which I do quite a bit of that.
Fundraising for?
Avon.
Avon, okay.
Why Me.
Why Me.
Susan B. Komen.
Okay.
Life with Cancer.
Sure.
I'm not in an official kind of counseling position, but I guess my approach is to sort of befriend people on one-on-one and just let people know that there was somebody there for me who was, if anything, sort of a breast cancer buddy. And she was someone I could ask questions of that, no offense, Dr. Robert, but the doctors just weren't in a position to answer because they were more of emotional. When you woke up from your surgery, what was it like? How did you feel? You know, could you look at yourself and what was that experience like? And I asked my surgeon that question, you know, what will my response be? And the answer is everyone's different, right, because they can't possibly know. But having somebody who has been there, who can hold your hand and be with you through that process.
It's a pretty scary process.
It is very scary. And you know, the other thing about it is a process. You don't go have one test and you know everything you're going to know. I felt like it was a roller coaster. We thought we knew something, have another procedure, we'd get more data back, and it would change things. And so emotionally, you're kind of going through all this. And I think it took my husband a little while to kind of catch up. Yeah. And in fact, it was in your office that this emotional roller coaster hit him.
It finally made sense. Well, yeah, we do have some websites which we will show on the screen, places where you can get information about breast cancer and places where you can get support if you have a diagnosis and you haven't been referred to one. There are lots more things to talk about. I know that, you know, one thing that I did hear here is that when people got their diagnosis, they took it seriously. They went to their doctor. They did what they were directed to do, and they had, so far, you all have had pretty good outcomes. And there are lots of alternative strategies, and I discourage people from running to the internet and looking for some alternative strategy to discourage them from doing what their doctors are recommending, because the science is there, and there's a lot of fabricated options that you might find there. So stick with what your doctor recommends. And I want to thank you, Dr. Robert, for spending your time with us and sharing your knowledge with us and your experience. It's been very useful, and I thank you all for being here. It's an important part of life to go through these trials and hopefully some tribulations along the way. And you've helped people learn about breast cancer, which I hope you've learned that you have to get screened, you have to be aware, you have to think about where in your life it's important, and make sure you get your regular checkups, especially after the age of 40 with your mammograms. I want to thank you for joining us here on The World of Medicine, and until the next time, I'm Dr. Russell Libby, looking out for your life. So now we're just going to talk